Good afternoon, dear friends. Good afternoon to this Aacci International webinar. As a part of this ongoing webinar, today we will, dear friends, just a second. Good afternoon to this. So, Aacci is an organization which started in 2007 under the leadership of late Dr. R.D. Lele sir, followed by his daughter, and the executive director of Aacci, Dr. Swati Bhave ma'am. Since last 17 years, Aacci has worked for adolescents through training of teachers, parents, grandparents, and youth and children, and has been working tirelessly in various streams, targeting of different medical conditions, psychological conditions, and life skills of our adolescents so that they become better citizens of this country. We have centers in nearly 11 cities of India and volunteers, more than 250 volunteers, who are themselves professionals, doctors, adolescent experts, lawyers, and different specialties. We have our four forums: Youth Forum, Parents Forum, Teachers Forums, and Grandparents Forum. For more details, you can visit our website aacci.in, where you can get the details. Today, as a part of this series, we have from Brisbane, Dr. Upasna Kapoor. Ma'am is a general pediatrician with over 2 decades of experience, and she works in both private and public hospitals in Brisbane, Australia. She is interested in adolescent and trained in child and adolescent psychiatry and has a special interest in behavioral and developmental pediatrics. In addition to the clinical practice, she is a lecturer at University of Queensland and a member of Assessment Committee of Overseas Trained Physicians. I just got to know that she was a medical graduate, MBBS graduate from my dear city of Pune, from the Bharati Vidyapit Medical College, and she has completed her DNB in pediatrics, followed by her fellowship in Loyal Australian College of Physicians. So, ma'am has a two perspectives, not only as a pediatrician, which we do day in and day out, but also as a psychiatrist after her certification in the. And these both viewpoints are very important for today's topic, which is ADHD. Friends, over the last few decades, you will see that the incidence of such behavioral problems has been risen. And also, the awareness of these problems in the parents has risen. So we have to learn ourselves to deal better, catch these cases early, and help them, or the children as well as the family, to cope up with them and sometimes to give them optimum life skills. Dr. Upasna Kapoor will help us and guide us for this session. I welcome Dr. Kapoor, ma'am. Kindly, ma'am, start your video and share your presentation so that we can start the session. I hand over for just one instruction. Any questions you have, you can put in the chat box during the webinar, or at the end of the session, I will request all the audience to kindly share the questions. So anytime, any question, this we will have a one-to-one discussion after ma'am finishes her presentation. Thank you. Ma'am, you can share your screen.
Can you see the
Yes,
slides?
yes, ma'am. You can put in the full view.
Yeah. Is this okay?
Yes, ma'am. You can.
Okay, so thank you for asking me to speak on this topic. So my name is Upasna. I'm one of the pediatricians working in Brisbane, and I'm a very proudly Indian trained pediatrician. And I work in Brisbane, which is a place in northern part of Australia. This is just a view of Brisbane, and if you haven't heard of it, you probably will hear a lot of it because the next Olympic Games are going to be hosted here. So coming to management of ADHD, I think when we've had a very good discussion with Dr. Anaga last time about what ADHD is, what it looks like, what is the presentation, what difficulties children with ADHD face. And she covered a lot of things around also managing and identifying and supporting children with ADHD. But I wanted to touch upon management of ADHD from a pediatric perspective. So, like you've already said, there has been an increase in the number of children who are being referred to pediatricians for behavior problems. And ADHD is one of the diagnoses underlying for children who are facing difficulties with their behavior or learning or even their social interaction. So I think the first thing that I would like to say for ADHD is that we need to have a thorough assessment. We need to be able to assess the child with the behavior problem in the context of the background, which will include the psychosocial history, the medical history, history from school, all of that, and then try to sort of narrow down whether he is a child who meets criteria for diagnosis at all or not. And if he does meet criteria for diagnosis, how do we need to manage them? So management of ADHD is recommended to be a multimodal approach. So there's pharmacological management as well as non-pharmacological management. So typically when a patient is referred for behavior problems to me, I take a detailed, we need to take a detailed history. We need to do a detailed examination, and I'll just highlight a few points that I think are really important when we're dealing with a child with behavior problems. The growth parameters need to be measured, which I'm sure all of us do as a routine for any pediatric patient. But this becomes particularly important here because majority of the treatments that are used for management of ADHD can impact growth. It's important to understand whether the child may have or has risk factors for developing nutritional deficiencies, because a lot of the children with behavior problems often will be fussy eaters. And very often we will see that their food choices are limited. Such children are obviously at a very high risk of developing iron deficiency or B12 deficiency or other nutritional deficiencies, all of which can impact behavior. The other thing important, and I'm sure you must be seeing a lot of it in your practice as well as I do, sleep and screen time. It is becoming such a big issue. Sleep problems in children, what time they're going to sleep, how are they going to sleep, do they have their TV, iPad, video game with them in their bed? Are they doing screen time? How much of screen time and what kind of screen time they're doing? All of that can impact behavior, particularly for boys who are seeing quite aggressive video games or playing those video games where, you know, they're expected to have the dopamine rush. So all of that history is important. And another common one is taking a neurological history. I'm saying epilepsy, I've written down in the slide, but epilepsy, particularly I'm talking of absence epilepsy. So particularly with girls, some girls may look like they're lost and they may be inattentive ADHD, but there could also be an absence epilepsy kind of presentation. So I think it's really important to take the history in detail and be sure that, you know, we're not misdiagnosing. The other thing I think is also very, very important is understanding what is the impact of the behavior problem. So how is it impacting the child's learning? How is it impacting the child's social interaction? Is there a problem at school in interacting with kids? Is the child hitting other children? Is it impacting his relationships with his friends? And what is happening at home? Are the parents struggling to manage him? Are the siblings struggling? Are they hitting their siblings? What sort of functioning overall the child has within the school setting as well as the home setting? And based on this, we can make a better management plan. So you could have a child who's hyperactive, inattentive, and would meet criteria for ADHD, but he could be doing fine at school and at home. So he then will not be a candidate for medication. He will probably then be a candidate for non-pharmacological management. So I think that detailed history is really important. And comorbidities. I mean, a lot of patients with ADHD will have coexisting specific learning disorders like dyslexia, intellectual impairment, autism, and speech and language. Why it is important to keep these in mind is because when we treat ADHD, in order to see good results, in order to see significant improvement, it is very important to be able to address all these issues. So if, for example, I treat the ADHD and I miss the dyslexia, then the child is still not going to be able to make gains in his learning, despite being on treatment. Does that make sense?
Yes, ma'am.
Okay. So after a detailed history, the next thing that we do is there are lots of tools that one can use to make a diagnosis of ADHD. Conners rating scale and the Vanderbilt ADHD diagnostic rating scales are the most commonly used ones. Most practitioners in Australia use Conners, but some may also use Vanderbilt's. Vanderbilt's is also a very well recognized tool. The difference between the two is that Vanderbilt is easier, freely available. You can just download it from the internet, print it out, and you can give it to the parents, one form to the parents, one to the teachers. Whereas Conners is a little bit more exhaustive and more expensive. But it is a really good tool. I use it a lot in my practice, and I find it very helpful. So basically, Conners rating scale is a questionnaire-based assessment, and it asks specific questions around the behavior of the child, and then the focus, attention, emotional regulation, and other sort of areas of functioning. So not only does this tell you, basically it helps us understand the severity of the problem. So number one, it will help in diagnosis. So for example, if we are scoring on inattention, hyperactivity, and impulsivity, what it will do is it will give a number to the problem. And when it becomes black and white, it is easier to diagnose. But when it is, sometimes history can be very subjective. So sometimes parents can say he's hyperactive, but how hyperactive? All 5, 6 year old kids can be hyperactive. But when we score it, then we know exactly how high he's sitting on the scale. So diagnosis becomes easier. And then it also checks the impact of that hyperactivity, impulsivity on the child's day-to-day functioning. So this is what it looks like. And basically, parents or teachers will score 0, 1, 2, or 3. And after that, the score is collected, and then a graph is formed. So I'll just come to that in the next slide, but we can get two types. There's a parent and teacher one, and there's a self-report. Self-report, it says theoretically you could give it to children over 8 years of age, but I don't think a lot of 8, 9, 10, 11, 12-year-old children with ADHD have a lot of awareness about their symptoms. So I generally use self-report for 15 and above. So again, this is where what the Conners does. It looks at hyperactivity, inattention, and impulsiveness. So these are the 3 core symptoms of ADHD, which we need to have if we want to make a diagnosis of ADHD. Now, these symptoms can have an impact. Let's go back. These symptoms can have an impact on all these conditions. So social difficulties, compulsive behaviors, emotional dysregulation, aggressive behavior. This is by far the most common problem I see in my patients with ADHD. And then learning difficulties, anxiety, and perfectionism is basically just another manifestation of anxiety. So Connors asks these questions, and it will ask, basically what it does is asks questions based on diagnosis of ADHD. So it's looking at how often does a child struggle with temper outbursts? How often do you fail to pay close attention to details? How often does he feel restless? These kind of questions answered by teacher and parent. And then each statement is scored from 0 to 3. Once all the answers are in, they're converted into a T score. Now, there was a time we used to score this manually, but now we have softwares that will do it for us. So we just get a graph and we can then share the results also with the parents. Typically, they say, this is what the graph looks like. Typically, they say that any child scoring above 65 to 70 in a particular domain is considered clinically significant. So as you can see in this slide, the red graph is the score by the parent, and the green graph is the score by the teacher or self, whatever that may be. And when and this is done in inattention. So these scores are given for inattention, hyperactivity, impulsivity, learning problems, executive functioning, defiance, aggression, peer relationship, and family relations. Now, for each particular domain, the child will get a score. So for a parent, here it's 68. And for the self-report, it's 67. So they say that usually over 65 to 70. There's a little bit of a range there, but 65 to 70, if the child is scoring higher than that, that means the problem is clinically significant. What that means is basically that the hyperactivity is significant enough to be impacting the child's day-to-day functioning. And that is when we get concerned. So then it also gives us how far the problem is seeping into the school area, the home functioning, all of those can be scored. And then there's another graph that comes up through that is whether the child, just particularly looking at just the core symptoms and the comorbidities. So we know conduct disorder, oppositional defiant disorders can also be coexistent with ADHD. This is the Vanderbilt score. As you can see, it is much simpler. This is easy to obtain from the internet. It has been approved by American Academy of Pediatrics. It's easy to do. It takes only about 10-15 minutes to do and maybe another 10-15 to score. So if you're in a clinic setting and you don't have access to Connors, you could certainly use the Vanderbilts as well. Is this making sense?
Yes, ma'am.
Any questions?
Right now there are no questions, but we'll get the questions as the session goes ahead.
Okay. So this is, I'm just going to present a case. This is Rahul, 7-year-old boy who has been having some behavioral difficulties. So the parents report that he's not following instructions. He's frequently losing his temper, having, tantrums, is constantly moving, climbing on furniture, cannot sit still, and keeps hitting his younger sister at home. And the teacher has reported that he's failing all his subjects, constantly interrupting the teacher, hits other children in the playground, disruptive in the classroom, and does not have any friends and not invited to any birthday parties. So anybody wants to give any thoughts on this? How would you approach?
Anybody from the audience?
Yeah. So first thing is you also want to take a detailed history. That's the first thing. So going on to the background, it was a term delivery, normal vaginal delivery, cried immediately after birth. Neonatal period was difficult for the mother. He was very unsettled baby, and mom had a lot of difficulty and found herself crying and really struggling to manage the baby. And currently in his sleep history, it takes a long time to fall asleep. So 2 to 3 hours, he's tossing in his bed, needs to play on his iPad to fall asleep, and wakes up tired in the morning, not wanting to go to school. He's a fussy eater, likes to eat pasta, noodles, and sandwiches. He avoids all fruits, vegetables, and does not have any meat. And in the family history, the dad reports that he also struggled to get good scores in English. And dad also has an anger problem. And mom is a very shy, reserved lady and gets easily worried. So I would like to know what the audience thinks about this case. How would you like to proceed?
If anybody from the audience wants to
More
come in, they
family
can
back-
unmute. Yes.
more family background is needed, and the family history and the home atmosphere we have to take the care.
Yes, that's correct. So anything in particular you would ask?
Regarding the any history of the problematic behavior at the home, or some problem is going on, that may be the hamper the routine daily life of the child, and that may lead to the more such type of the problems.
Absolutely, absolutely. So you're thinking of what kind of, is there any tension in the family? Is that what you're saying?
Tension in the family, or there may be of some internal conflict between the parents is going on.
Thank you. Yes, that's right. So that's one thing you definitely want to see in any child presenting with any kind of behavior problem. Absolutely right. Anything else?
We would like to get a history whether different settings. So how is he when he's playing with friends? How is he when he's in school? When other, if maybe he's going to some classes. So is this behavior pervasive everywhere, or sometimes the children are very throw tantrum at house, but outside they are very polite, or in the school they don't have any problems. So we'll have to see compare those behaviors at different settings.
Absolutely, absolutely. And why is that important? That is important because you technically cannot make a
Parental bias.
diagnosis of ADHD unless the problem is in at least two settings. That is the DSM-5 diagnosis.
Right.
The many times what we see is children with means permissive parenting, they throw tantrums at home, but they know how to regulate their behavior in other settings. So that will help us differentiate between those kinds of behaviors also.
Absolutely, absolutely right. So as we move on, again, you want to assess the patient in detail. You want to know whether there is any of these factors that is impacting the behavior. So sleep, obviously, he probably will not be getting enough sleep if he's waking, if he's taking that long to fall asleep in his bed. Quality of sleep will be impacted by the use of iPad. So if sleep is not in place, then no child is going to be well behaved the next day morning, right? So that's the first thing. Second thing is screen time. He's obviously playing iPad just before bedtime, but is he getting excessive screen time during the day as well? And this is a huge problem. I'm sure you must be seeing as much as I'm seeing here. Children like 10, 12 hours of screen time. And that's not uncommon, unfortunately.
Yes, very true.
Yeah, it's a big problem. And not only is it leading to behavior problems, but I think even the content that they are seeing is so hard to monitor if they are on their screens for 10, 12 hours a day. So all that has a huge impact on behavior. And then iron deficiency, very common, and definitely has to be screened before we start medication, because that's one thing you want to correct. And like you've already pointed out, parenting, what is going on at home? We can easily now, in this case, father has got anger problem, mother is quiet, reserved, and easily worried. So it is possible that there will be a huge difference in the parenting styles at home, which is very confusing for children. And they may have behavior problems as a result of that. And then history of postnatal depression. So that's something I feel, again, we have to always go back and ask for the postnatal history, because it is very well known that mothers who have postnatal depression and anxiety, and the incidence of that is as high as 80%. So mothers who have a history of that will struggle to develop a secure attachment with their child. And so if the attachment with the mother is not secure, then what we can see is reactive attachment. And reactive attachment is typically a condition where you see a child who's explosive, he's aggressive, he's hitting, biting, all those sorts of things. But that is why it becomes very important to ask the mother's history, or both parents, but particularly in the postnatal period, the mother's mental health history. And a lot of mothers will not even know that they are going through postnatal anxiety and depression. And a lot of them will report that I used to be teary. So I think that is also something to keep in mind. And then, like you said, more detailed history at school. What supports are being offered? What is the degree of the problem? And is the teacher doing anything to help the child?
One important thing is, madam, child is elder child. We are definitely keeping the sibling rivalry behavior is the very common thing, showing this type of the behavior in the elder child.
Yes, that's true. Sibling rivalry definitely have to keep in mind, but that could be within a physiological range. But
Right.
if the problem is really severe, he's hitting his sibling, the siblings are not seeing eye to eye, they cannot sit together, they cannot sit for 2 minutes together without fighting, then that, I think, becomes an issue eventually.
Right.
So in this patient, I would give them a Connors questionnaire, or we could also do a Vanderbilt's. And I think it's a good idea to contact the school and the teacher to get more information about how he's going at school. And like you rightly said, how is this interaction in the playground? How is he with the other kids? What is his interaction like? And then school observations. I'm not sure whether that is possible there, but here a lot of psychologists will go and visit the school and see the child in the school setting. So that gives a very good, some very good observations about the child's behavior and really helps with diagnosis and understanding the developmental profile. So in this child, once we have done the Connors, so on the basis of the history from the parents, history from the teachers, we will have a strong suspicion of ADHD. So in order to consolidate the diagnosis, what we can do is we can do those Connors questionnaires and see what the scores look like. For the sake of simplicity, let's say he scores in the 90th centile for hyperactivity, impulsivity, inattention, social problems, and academic problems. Chances are if he's failing all his subjects, he probably will be in the 90th centile. So once you have all of this and you have the Connors, you can safely make a diagnosis of ADHD. The next thing is, how do we manage? How do we make a management plan for this child? So in the management, it has to be a multimodal approach. So including pharmacological as well as non-pharmacological management. And even if we are using medication, it is recommended that we use the non-pharmacological methods of management irrespective. So I'll go into the details of that. But what the evidence shows, and in all the research and the guidelines that are there, whether it is the NICE guidelines or you go through the American or Australian guidelines, all of them have recommended that there is enough evidence to say that when pharmacological management is used in conjunction with non-pharmacological techniques, the outcomes are much better. So now that we have seen the child, we have made the diagnosis, he's a 7-year-old boy. He probably will meet criteria for ADHD and using medication. So now the next question is what medication and how do we start the medication? So pharmacological management is again, which medication to choose, starting the medication. Once you start the medication, you have to monitor the child. You have to discuss the choice of medication with the parents. And then we need to know how we stop the medication. So when we are using medications, I think this is a really a sensitive topic to touch in the clinics. And I think, like I was discussing earlier, there will be two types of families. There will be families who absolutely want medication because they're at their wit's end, they can't manage the child. And then there's another category of parents who are very reluctant to use medication because of the stigma attached with the medication and the diagnosis. So this is the time where I think investing some time in just counseling the parents about what the medication can do. And we have to be very clear after the assessment that the child will benefit from medication. We have to be clear what is it that we want to achieve through the medication. So when we start medication, what we want to see is symptom reduction. Symptom reduction basically means reduction in hyperactive, impulsive, and inattentive features. Now, the secondary outcome of this will be automatically the child will be performing better academically, automatically the social interaction will get better, and automatically the interaction with the parent child, sibling child will also get better. So those will be secondary outcomes. Now, this is the time where it's very important, I think, to work through what they call decision making we have to work as a team with the family, isn't it? We have to understand what is the family's expectation, what do they want, and then we can just guide them based on our experience, knowledge, whether the child is likely to benefit or not. We can only say whether he's likely to benefit or not, because if even though like medications have a very good outcome, I think there is excellent response to medication for ADHD. There always is that 1 to 2% of patients who will not respond to medication or will have significant side effects because of which you have to stop the medication. So I think being realistic, being honest with the parents is important. And then talking through what are the effects we are likely to look at and what are the side effects which are likely. So those are the kinds of things I would recommend we discuss in the clinic. And we know that we have to look at it. There will always be some side effects. I mean, there are some patients who have no side effects, but most patients will have something or the other. So it will be a balance of effect versus side effect kind of thing that we have to do. And for monitoring height, weight, BP, every appointment has to be done. So when we come to medication, we've got the stimulant and the non-stimulant category. And then broadly, we divide the medications into short-acting and long-acting. So stimulants are the most commonly used medications for ADHD. And they are by far the most effective for treating the core symptoms. And stimulants basically act on the part of the brain involved in controlling attention and arousal. They definitely improve concentration, impulse control, hyperactivity in almost 80% of the patients. So in the stimulant category, we have two major drugs. One is the methylphenidate, which comes in the name of Ritalin over here. And then we've got dexamphetamine, which comes in the name of Vyvanse and Dex. Dex is the short-acting form and Vyvanse is the dexamphetamine, which is the long-acting form. The moment you say stimulant, I think a lot of parents think that they will be addictive drugs. And invariably, there are two things that parents will almost always ask. One is, what are the side effects of this medication? How long do we have to give this medication? And is the child going to get addicted to the medication? These are the three things I almost always have families asking me, and we have to be prepared with these answers. So the thing to say is that stimulants are not addictive drugs. However, children with ADHD, in terms of long-term prognosis, are more prone to drug abuse than children without ADHD. Yeah. So what we need to understand is that... Is there a question there? Somebody asking question?
No, it is some disturbance. You continue, ma'am.
Okay. So what is important to understand is that whilst the drugs are not addictive, the child per se, as a result of the ADHD, may be more prone to drug abuse and addiction, which is what the research has shown. I say to parents that if we treat the ADHD, we actually have a lesser chance of child getting into drug abuse and alcohol later on in life than not treating the ADHD. So that's what puts them to rest. The other thing is what they want to know, whether there is any side effects and what are the long-term side effects. Again, side effects are for both the categories, both Ritalin and Vyvanse are quite similar. Most common side effect is headache and tummy aches. And headaches and tummy aches usually subside in time. I usually say to parents that if it is not too problematic, just persevere. In about 10 days, that usually subsides in time. Another common one is loss of appetite. That is something we most often have to deal with. This is by far the most common side effect of stimulants that stays so long as they are taking stimulants. So if the child does develop that, we have to be very sure that we are measuring their height and weight and their growth is not impacted. We need to be sure that we are not missing any nutritional deficiencies in that child. But the way to work around it is to ask them to have a very good breakfast and give the medication just after breakfast. So I tend to advise a breakfast which is rich in good fats and protein in the morning. And then if the child misses the lunch, which is what he's most likely to miss, it's okay. Usually these children will come home and have a very big, snack and then dinner. So overall, they kind of compensate for the day. So these are the common side effects, but the uncommon side effects are sleep difficulties. This becomes a little bit tricky because a lot of children with ADHD have sleep difficulties without the medication even. So that is something we have to tease out carefully. But sleep difficulties are known to happen with stimulants. And the other one is sometimes, and this is very rare, but sometimes the child can show opposite effect of what we are targeting. So they might become more hyperactive, more agitated, more impulsive. And sometimes they can get too subdued. So they may get too depressed, too, low mood. And you'll see that parents might say, he's always crying, he's very subdued, he's become like a zombie. These are the words they use. In that situation, it is good to sort of just cut back on the dose because chances are that you've probably over-medicated for the child. Now, the other problem in this field of treatment is that unlike other medications, we don't have milligram per kilo dose. So we have to titrate the dose based on the effects that we are seeing in the child. If you do decide to start the child on Ritalin, it is a good idea to do a trial for 4 weeks. And the most recommended way of doing that is week 1, you can just say, take half a tablet in the morning. Week 2, take half in the morning and half at lunch. And week 3, 1 tablet in the morning and half at lunch. So this is just a ballpark figure of what most patients respond to. But I generally call them back in 4 weeks' time and then do the dose adjustment as needed. Any questions so far?
Age of starting the medication and the age-specific dose adjustment?
So age of starting, that's a good question. Usually, these medications are not prescribed before 5 years of age. Most common age at which these medications are prescribed is around 7 to 8 years, which is when the child is in grade 1 or grade 2 and everybody is clear that there is a problem. Usually they say that in children less than 5 years, and these are the American Academy guidelines, that children less than 5 years of age are more likely to respond to non-pharmacological management. And the scientific basis behind that is in the neuroplasticity and early intervention supports for the child. So pharmacology becomes an option, I would say, not before 5. I will generally resist. I will do other things. I think it's good to sort of address everything else. If you have a child who's less than 5 years of age and is presenting like ADHD. And the other thing to remember also is that ADHD essentially is a deficit in executive functioning, which is the frontal prefrontal lobe. Now, that executive functioning doesn't get consolidated up until 10 years of age. So giving the child time with the appropriate supports is not a bad idea if you have a child who's less than 5 years of age and presenting like ADHD. Does that answer your question?
Yes. Second question is, how long do you give?
How long do you give the
So if
medication?
the symptoms decrease and parents want to give a trial, so do you give trials of medicine-free period and then stop it, or
Absolutely.
we target it sometimes that at least till teens he will require? Is there any
Yeah.
guideline, or each child responds differently?
I think it is very individual. There is no doubt about that. But uh, it is recommended. The better way of treating with stimulants is if you can give a break over the school holidays and weekends. That is a better way of treating with stimulants. Why? Because it alleviates the side effects. For example, if the child has got appetite suppression, which a lot of children do develop, then as soon as the medication is stopped over the weekends, they will eat a lot. So the weight gain problem becomes less. Second thing is, every 12 months, one can stop the stimulant and see if the child is doing fine without the stimulant. If the child is doing fine, there is no need to go back on it. And there is a very good chance that the child may do well because every year the executive functioning and the brain maturation is improving. And if we have really done a good treatment of the child and we have given supportive therapy as well, so what that means is we've spoken to the parents, we've given them education, parents are handling the child better, the child's self-esteem is better, the child starts performing better at school, is sleeping better. All of these things together can make a huge difference to the symptoms of ADHD. So what looks like ADHD today, in 5 years time, the child may have no ADHD symptoms. That is certainly possible. So I think every 12 months, giving a trial of the medication is not a bad idea. Sometimes parents forget to give the medication, just forget to give the medication. And the teacher at the school will call the parents and say, what has happened? He's very hyperactive and hard to manage. So in that situation, you almost know that he needs the medication, right? Then when do we stop the medication? Now, a lot of the children, once they are 16, 17, 18, or in their early 20s, they learn to manage their symptoms and they may want to go off the medication. And that's a very common thing I see among the late adolescents. They would go off the medication. And if they manage well, that's fine. We don't have to go back. The other thing to remember is that as the executive functioning improves with age, the need for the stimulant medication also keeps going down. So titrating the dose is a 6-monthly to 12-monthly process. And also to not forget that ADHD as a behavior problem is impacted by a lot of things. So sometimes what happens is that you have a child in grade 2, you start him on medication. Come grade 3, he has a good teacher. The teacher is understanding, supportive, and you see that the child has no problem. So environmental factors will also play a big role. Sometimes there's stress in the family, there's a death in the family, and you will see that the child is having problems despite being on treatment. So titrating based on that is really, really important. There is a percentage of people who will carry their ADHD into adulthood. And I'm not sure about India, but in Australia, the adult diagnosis of ADHD is becoming very, very common now. So those people obviously benefit from some medication even into adulthood.
So are
What
there
is the maximum dose?
So maximum dose in Ritalin, it will vary from medication to medication, but I know that Ritalin is one of the main ones available in India. So for Ritalin, I don't recommend, or the recommended dose is not over 60 to 70 milligrams, irrespective of the weight.
Total.
Yeah, you would never want to go over 60 to 70.
Okay.
Are there any factors which decide which patients will benefit more? So maybe the children who are, I'm just hypothesizing, diagnosed early, or the children who are more impulsive or more hyperactive. Are there any categories of patients, or is it that we don't know and some children may miraculously react more than others? Or do we know the factors in this?
My understanding is that as far as the research for this goes, so far, there is nothing in literature to suggest which child is going to respond and which child is not going to respond. Which child is going to respond to which medication, even that is not known. But what we do know is stimulants, 80% patients will respond. So
Same, in connection to same question, is there any score limit? What we are, you just described that the corner scoring is that this score we must start the medication.
See, first thing, what is important is that based on your scoring, based on your clinical judgment, child needs to meet criteria for ADHD. So he has to have a score over 70 in at least 2 of the 3 criteria, which is hyperactive, impulsive, inattentive, hyperactive, impulsive, and inattentive. So out of these 3, at least 2 should be scoring above 70. Even before that, you cannot think of medication. So it is not even indicated that you give medication. So that's one thing. Whether or not you want to trial medication is a very subjective and individualized decision. So what needs to really happen is in the meeting that you're having with the patient and the family after you have got the scoring tool, if you have done a scoring tool, some pediatricians don't even do a scoring tool here. And it is not mandatory that you need it. If you're so sure of your clinical judgment, you can go ahead without that. But most people will do a tool. I will almost always do a tool. So what needs to happen is you need to have an understanding of what are the factors that are leading to the ADHD symptoms. If you have a child who clearly looks dyslexic to you, or you have a child who's clearly looking like intellectually impaired, then that child will also show symptoms of ADHD. Is this making sense or am I confusing you?
No.
So why that will happen? Let me explain that to you. If you have a child who has dyslexia, he goes into the classroom. He cannot read. He just cannot read. And 80% of the class is reading. The teacher is expecting him to read. The teacher is complaining. Teacher is screaming, shouting at him. He is not able to read. He goes home. Parents complain. Parents force him. He is not able to read because he has dyslexia. This child who cannot, yeah?
It's not adjusting to the environment. That's the basic reason.
No, it is not about the child adjusting. It is about us understanding the child, isn't
We
it?
understand. Yeah.
Yeah. So if a child is made to spend 8 hours in an environment that he is just not cut out for, he just cannot read. It's not his fault. His brain cannot read. So he will play up. What will he do? He will start looking out of the window. If somebody gives me a piece of paper that I cannot read and forces me to read it, I can't. I will start looking out of the window. I will start playing up. I will start talking to the child next to me. Isn't it? And these are the same symptoms you will see in ADHD. So before starting medication, that is where your clinical judgment comes into play. That is where you need to analyze what is going on for this child. Just because he's scoring in the positive range, he may not always need the medication. I think that teasing a part of the developmental profile is also equally important. Does that make sense?
Yes. One more question I had, not regarding only medications, but you told that your psychologists sometimes go to schools and then they interact. So how is this coming? So for management of ADHD or behavioral issues, many times we require the help of this teachers, school settings. So how is that environment in Australia? Because in India, many places we don't get any cooperation in schools. Some schools we get the cooperation, the teachers want to help, but the system itself, because of the number of students available, the resources available, they hardly can do anything about it. So how is that scenario in Australia?
I will say it is better than what it is in India. The teachers understand. So I think first thing first, understanding the fact that there will be children who will have behavior problems, not because they are bad or naughty kids, because they genuinely have a developmental disability. I think that one fact needs to be understood. Because what happens is then if there's one child who's not able to do the things that the teacher is expecting them to do, then he becomes the naughty kid. So I think that one fact has to be drilled in nicely. And in Australia, that fact is clear. That the teachers know that there is that percentage of patients or children in the classroom who will have some difficulties. So that is one thing. Second, understanding, Some schools here can be fussy, but most schools, most patients, most teachers that I have spoken to, I feel like they want to help because they are also struggling with the child in the classroom, isn't it? So they also are looking for advice from us. So that I think may be a little bit different here. And the third thing is that most schools, at least all public schools, have got what they call a special ed teacher. So the special ed teacher specifically works with children who are struggling with their learning or in whatever area they may be. Even if they are struggling with social emotional difficulties, there will be a special ed teacher who can help them. So those facilities are available. They are not foolproof. They are not, I mean, I would like to see more as a pediatrician. And I think more education needs to be given to the teachers as well. You know, it's sometimes a case of ignorance. And also, to be fair, behavior and development as a branch of pediatrics only came about in the 80s.
Yes.
So a lot of people are still not aware of that.
Just want to discuss. One patient of mine had come from Canada to our CDC, and there they had diagnosed the child. And what I found is once the child was diagnosed in Canada and it came into the system and he got that, the help from their health services itself came because they used to come to home and then assess the child. They used to keep a follow up that this is required. So they have a proactive in this. So is that the case in Australia also? Is it depend on the parents' willingness to continue it? Or is the health system itself go vigilant enough to once the diagnosis has been caught to help the child throughout their needs?
Um, so here, there is a lot of help available through the government for families. There's extra funding also given to parents who have children with disabilities. But I'm not aware of people who would go home to administer medication or make sure that the medication is being given. Because at the end of the day, our role is only as pediatricians to give our advice. Whether a patient wants to medicate their child or not is again the right of the parent, right? So that is something we have to honor. The second thing is sometimes it is possible that the child may have like really dangerous behaviors. For example, he may be running in front of a moving car, or he might just want to open the door and jump out of the car. And I've had one patient like that in my clinic who was about to jump out of the window. And so those kind of behaviors, then the parents are mandated to treat. And if they don't, then they are doing a harm to the child. In that situation, in Australia, as pediatricians, we are mandated to report to child safety.
Okay. One more question is, do you see ADHD treatment, management, presentations different in girls and boys over there? Or is that gender only because of child rearing practices in India where we see a huge difference? Or is it the same in Australia? And how do you go about it?
Yes, so it is very well known. Autism and ADHD in girls will present very differently to boys. Um, I think it's also got to do with the prevalence of comorbid features. For example, anxiety. Anxiety typically in children will present as internalizing behaviors. So they will be more internalizing their emotions. They will cry, they will go into their room, they will hide in their room. Not that you don't see that in boys, but this is more common in girls. So these children can often get missed. The girls are often missed. It's very common for girls to get missed. Also because girls have a higher prevalence of inattentive type of ADHD, whereas boys have a higher prevalence of hyperactive impulsive. So if a child enters your clinic room and wrecks the room and is climbing on the sofa and the chair and everything, it is so much easier to pick that child up as an ADHD child. Whereas if you have a girl who's sitting quietly in the chair and her mind may be somewhere else, she could be completely inattentive, but it's so much more hard to pick that as a diagnosis. That is why girls are often missed. Does that answer your question?
Yes, but medications and everything, you start at the same level or?
Absolutely the same. Management is absolutely the same.
So do adolescent age in this when there is puberty changes? So are these medicines affecting that in any way, or do we need to be careful about it, the doses, anything?
Growth, yes, you have to monitor. Because growth can be impacted. Long-term outcomes with height with stimulants have been found, but usually it is not a problem. The patients that I have been following up now that I've been in practice for that long, the kids that I started seeing at 7, 8 years of age are now, almost finishing school. They do very well. They do very well. I don't think a lot of them have had issues. The one thing to remember, though, is that the presentation of ADHD does change in adolescence. So once they enter high school, um, you know, you may not see as much of hyperactivity. Hyperactivity is more seen in primary school age group, whereas in high school age group, you see other repercussions of ADHD, which could include difficulty in organization, difficulty in remembering things, difficulty in, like what normally is put down to procrastination. So starting a task, finishing a task, all of those things are harder for these kids, and they are forgetful. So that is just the difference in presentation.
We can continue, ma'am. Any questions? If further coming, I'll share it with you.
Sure. So then we have the other category, which is the non-stimulant medications. All of these medications are long-acting medications. Sorry, one more thing I wanted to say with Ritalin, just going back to Ritalin, after the 4-week trial, we have the option of moving to a long-acting as well. And methylphenidate comes in 2 long-acting preparations here. I'm not sure what you get, but we get a Ritalin LA and we get Concerta. Concerta is a 12-hour medication and Ritalin LA is 8 hours. But again, there's the other thing is that every child will metabolize the medication differently. So theoretically, we can say 8 hours, 12 hours, but effectively, practically, what you see in a child will again be based on the history that they will give you. So in the children who are high school age group, I tend to use the long acting because they generally need little bit of coverage to go home, do their homework and assignments, and they're into sports and all of that. So it's a good idea for older kids to be on long acting. So then coming to the non-stimulant, we've got atomoxetine, which comes in the name of Strattera over here. And then there's clonidine and guanfacine. So atomoxetine, I'll talk about clonidine first because this drug is used for multiple indications: ADHD, sleep, pain, and tics. Now, tics are a very common. I don't know whether is clonidine available in India?
Yes.
Okay, excellent. So clonidine is something that one can use in the afternoon. If you want a little bit of coverage beyond what your medication in the morning is giving you, you need it in the afternoon, you can use clonidine. We tend to not use stimulants in the afternoon because they can impact the sleep. Clonidine, in fact, will help with sleep. So we know that a lot of patients with ADHD have sleep difficulties as well. So if there are significant sleep initiation difficulties, you've done sleep hygiene, you've taken away the screens, they are giving enough time for the child to wind down, and still the child is not able to sleep, then clonidine is a good medication to use. So it not only calms the ADHD brain down, it also helps with sleep. And tics is another one because tics is a common comorbid condition with ADHD. So that also, if there are tics in the presentation, I tend to use some form of non-stimulants, whether it's clonidine or insulin. And again, the side effects are tiredness, dizziness, fainting, dry mouth, constipation, all of which are very manageable, really. But one thing to remember with clonidine is that it tends to impact the blood pressure. In fact, it is one of the antihypertensive medications. So every visit, we have to measure the child's blood pressure. Then we move on to atomoxetine, which is Strattera here. Again, it is
Madam,
a long...
dosage?
Sorry?
Dosage, clonidine dosage?
So clonidine, again, there is no milligram per kilo dose. Here it comes in microgram tablets. So it comes in 100 micrograms and 150 micrograms. So average dose for most kids is around 100 micrograms, which I use in the afternoon. Now, another advantage with clonidine is it can act like an adjunct to the stimulant medication. So you can use it in the mornings as well. But if the child becomes sleepy or dizzy, then you can't use it. So you can use it in divided doses as well. You can use it 2 to 3 times a day as well, if needed. But yeah, average dose is about 100 micrograms. Can go certainly up to 200 micrograms in divided doses. But again, there is no milligram per kilo dose. So now going on to atomoxetine. Again, it is a long-acting drug. It takes about 4 to 8 weeks to build up in the system. So for first 2 months, you will not see any response. It is not as effective as stimulants. So the smaller effect size than stimulants, but it has fewer side effects. And the other good thing about atomoxetine is that it helps in anti-anxiety effect as well. So again, anxiety is an extremely common comorbid condition. I don't think that any child with ADHD or autism will not be anxious. There's usually some degree of anxiety in most patients. So with atomoxetine, if you feel, if when you take the history and you feel that the anxiety symptoms are really significant, and it seems like anxiety is the most prominent problem in the presentation with a little bit of ADHD symptoms, enmeshed into it, then atomoxetine would be the drug of choice. But like I said, the number of patients that will respond to atomoxetine versus number who will respond to stimulants, much lower. But if it works really well. And this one, we go up in increments of 20. You can go up in increments of 20 milligrams. And it over here, it comes in 20, 30, 60, and 80 milligram tablets. Again, I don't think you can go over 60 to 80 because going over that dose, you can get reversal of symptoms. So again, you can get somebody who becomes more hyperactive, more impulsive, and that is going to be completely counteracting the effect. Is any questions so far? Can we move on to the non-pharmacological
Yes, ma'am.
management?
You can.
Okay, so with the non-pharmacological management, as I have already talked about, and Dr. Anaga talked a lot about, what strategies we can use, but primarily two broad categories are management at school, management at home. So management, first thing first, we have to make sure that basic things are in place. So sleep, diet, exercise, screen time, and relaxation time. I think these are 5 core things that we have to put in place for any child with behavior problems. So we've already talked about, the sleep and the screen. I mean, we can talk more about it, but usually what for sleep we recommend is that there are 2 things. There is quality of sleep and quantity of sleep. Most parents are very well aware of the number of hours, and they'll say, he sleeps 8 hours, he sleeps 10 hours. But what is the quality of sleep becomes the next question. So a lot of these children will have sleep initiation difficulties and sleep maintenance difficulties as well. Initiation being more common, I think. The advice, and if they say that, then the first thing to assess is what is the child doing 1 hour before bedtime. Very often there are screens involved. The whole family is sitting and watching TV, and then suddenly it's 8 o'clock, please go to bed. Mother, father, everybody is watching TV, child is expected to go to bed. That's not going to work. So what we recommend is that 1 hour before bedtime, TV screen removed, and the whole idea is to wind down. So we prepare for sleep for 1 hour. So what we need to do is some activity that helps the child wind down, which can vary from child to child. Some child likes to listen to relaxation music. Others would like to read. I think reading is a really good one that I always encourage parents to do with their children at bedtime. For multiple reasons, it helps. And some children like to play with their Lego. Anything that relaxes the child and helps them get into the routine of falling asleep is what we recommend. It is good to also have a fixed time every night to go to bed. So that helps with the circadian rhythm. And the other thing is having a good routine in place. So, and having the same routine every night. So it could be, it can vary from family to family, but some families would want to brush their teeth, take a shower, get into bed and read. That is the most common one that we see. And I generally think that that's a really good one to encourage. And that screen time again, I generally, we need to know how many hours a day the child is on screens. And nowadays here, I don't know what is happening in India, but here from grade 4 onwards, children are given iPads and screens to work on. So there's a lot of school work that is also happening on screens. So that needs to be also, monitored. And what is the child playing video games? Is he watching YouTube? What kind of content he's seeing on YouTube, what kind of games he's playing, all of that needs to be monitored, because all of that is going to impact the neurotransmitters in the brain and in turn affect the behavior of the child. Diet, of course, we want to give them a balanced diet. I generally ask about the variety in the diet. That's really important. If they are taking a little bit of everything, that's good enough. Exercise, I think we recommend at least an 30-minute exercise 3 to 4 times a week, whatever that may look like for the child. Any kind of physical activity is fine. I feel like anything is fine. They could be jumping on the trampoline. They could be jumping on the trampoline actually is a good one for children after coming back from school, because that's the time when the Ritalin has worn off and the ADHD is coming back with a vengeance. So typically children with ADHD after school, if they're allowed to do some physical activity, which could look like anything, it could be running around the backyard, it could be jumping on the trampoline, it could be a sporting activity, it could be just taking the dog for a walk, it could be anything that exhausts the child and calms the brain down for people who have ADHD. So that's a good one to sort of recommend. And relaxation. We know that relaxation, whether it's mindful activities or meditation, if the parents can sit and do that even 10, 15, 20 minutes a day, it's highly recommended for children who have any kind of behavior problem, really. So then the next thing that is important to talk to parents about is psychoeducation. So my experience, as I said, is that there are two categories of families. One that are in complete denial that there's anything wrong with their child. And then there's another category of families that really are at their wits' end. They cannot manage the child. They are tired. School is complaining. Parent is complaining. And they are just ready for a diagnosis and treatment. So I would like to know what your experience is when it comes to making a diagnosis. What kind of reaction do you all get from parents?
But we having a third category. Many times parents were taken for the granted. Okay, this is the behavior that will subside itself because it's a familial behavior.
Yeah, that's true. That's also common. And you know why? Because ADHD runs in families. Chances are that the child that you are seeing has a father who also had ADHD, and obviously the severity may vary, and he's pulled through and done well, so he thinks his child should do that too.
Yes.
So yeah, that we see here as well. So again, I think it's important to tell them that, your child is meeting criteria for diagnosis. This is a condition that is perfectly treatable. I think that's a really important and powerful statement to make with the parents, because once they know that we are dealing with a condition that can be treated, unlike a lot of other conditions like autism, you cannot treat. Specific learning disorder, you cannot really treat it. But ADHD is something we can treat, and we have really good outcomes when treated appropriately. So I think that is something that really helps parents understand. And then explaining to them what the diagnosis is, what that means, what are the likely outcomes with treatment, without treatment, what are the side effects of medications, what options we have for medications, all of that, talking through that is important. Second thing that is really, really important, I think, is talking a little bit about the parenting skills and how the parents need to manage those behaviors. I think that is a very important and often overlooked area And it can be very powerful in terms of the behavioral outcomes of the child. So sometimes we see patients with high level of autism. You could have a child with ASD level 3, and they may have even intellectual impairment, and they may have ADHD. But those kids do fine. They have no behavior problems. They are not on any medications. They have their struggles, but they are doing fine in terms of their behavior. On the contrary, you can have a child with just ADHD, and nobody, neither the school nor the parent, is able to manage them. The difference in the two families is just parenting. That's what I have learned over the years. So I always spend some time explaining to the parents that they need to understand the child's developmental profile. They need to understand that when you have said, put on your shoes to get dressed for school, and then just gone out of the room, it hasn't really registered there. This is what happens because children with ADHD typically have a low working memory and they have a slow processing speed. So in the morning, when the whole household is rushed up, parents are going for work, child has to get dressed for school. They come in, they say, wear your shoes. He hasn't worn his shoes. Then they come again, they wear your shoes. No, it just doesn't register. Even if it does register, it takes him so much time to really start doing the activity. By that time, the parent has given the third reminder, and now the parent has lost their temper. That does not help the situation. It really impacts the child's self-esteem and it gets no positive outcome. So explaining this to the parents is really important, that when you're giving instructions to the child, they have to be short instructions. They have to be clear instructions. Before you walk out of the room after giving the instruction, make sure that he has understood the instruction. Make him repeat the instruction. And if you have to give reminders, just give reminders. Which is asking for a lot, actually.
So what the parents, they are told, because they have behavioral problems, discipline comes very important. So what in discipline do you advise the parents?
Thank you for asking this question. Now, this is a very controversial approach, but I am a believer of attachment-based parenting, which is been researched for the last 20, 30 years all over the world. And what is attachment-based parenting is basically understanding the child, and it works on two golden rules. Follow the child's cues when possible and take charge when necessary. So these two golden rules, if we can follow, majority of the problems will be solved. So follow the child's cues when necessary. So if a child is playing up, he's not listening to you, he's having a tantrum, first thing is for the parent to understand why is the child. Chances are that in that situation, the child has got some need that has not been fulfilled. It could be any need. It could be a need of being heard. It could be a need of being supported. It could be a need for needing support with emotional regulation, right? So it could be any need that we have not been able to fulfill. Now we have to teach the parents, and this is a long process. It may be going off topic, but that is what it is, that you have to teach the parents to understand the child's profile and understand, because every bad behavior is a way of communication. So the child is communicating to you that I'm not able to handle this situation. That is why I'm screaming, shouting, crying, or having aggressive behaviors, right? So this is an understanding process that the parent needs to get. That's number one. Number two, the parent has to stay calm in that situation. That is another big struggle for a lot of parents. So staying calm in that situation, understanding the child. So these two things help with following the child's cue, but taking charge when necessary. So what that means is, if your child is saying, I don't want to go to school, and he's about to miss his bus, you take charge and say, no, you have to go. There is no debate on this topic. You have to go. Now, taking charge can be, you don't have to be rude. You don't have to scream. You don't have to shout. You just have to be firm. This is what is advocated in that. Now, talking about consequences, parenting discipline. Discipline, if you are following these two things, chances are you will be able to get your child and to do the things that you want them to do. Over time, that will happen. The other thing that comes up is a lot of parents talk along the lines of consequences. So if you haven't done this, which is actually another word for punishment. If you don't do this, you will not get this. That what the research has shown is something that does not work very well. Another thing that they say now is that we have to do positive parenting. What that means is, for one criticism that you have given your child, there should be 6 words of praise. So we are trying to move from a positive reinforcement. So that's the other approach. And the third thing is timeout. Timeout is you tell the child to go to his room, calm down, and then come back to you. Okay? What again research has shown is, by sending a child out for timeout, we are asking the child to self-regulate, which he is in the first place not capable of. That is why he's losing it. So that is not going to work. That technique is not going to work. What does work though is co-regulation. So where the parent and the child co-regulate. So first thing, you have to model the right behavior. Now, again, coming back to the discipline, I see so many times parents are eating Pepsi chips, but they're expecting their child to not eat. Parents are watching TV till 10 o'clock, but they're expecting their child to sleep at 8 o'clock. How is that going to happen? I think modeling is the first thing. That's what I think. That is what research has shown, and which is what we are talking of these days. Does that answer your question?
Yes, ma'am.
So moving on, how are we going for time?
We are only 10 minutes over time.
Oh, we are already over time.
Yes, ma'am.
Oh, sorry. I will quickly cover this. I can't keep track because I'm on a different timeline. So again, talking along the lines of non-pharmacological management, again, there are certain modifications that can be made in the classroom environment. So, for example, if the child is not sitting in his seat, he's, you're making sure that he's sitting in the front row, right next to the teacher. Teacher can keep an eye. He's not made to sit with the talkative kids or the distracted kids, where he's sitting. If he's having difficulty completing his tests in the allocated time, then he should be given extra time for his tests to be completed or assignments to be submitted. If he's getting easily distracted, the teacher can go and talk to the child and say, okay, if you need a movement break, you can go out, you can, take a toilet break, just because ADHD kids need that break. So just incorporating multiple, breaks in their day would help. Some kids have sensory needs and some sensory, like toys, like they call the fidget toys. They can be given. Some kids like to chew on their shirt because it's a sensory seeking behavior. As soon as they get anxious, they start doing these behaviors. And, then the occupational therapist will give them necklaces to chew on so that they can concentrate and yet have their need to move or their sensory need fulfilled. And we've already talked about this, again, we're talking of strength-based approach. So I think this is another very important thing to remember to mention to the parents, is that whether it is ADHD, whether it is autism, they both come with exceptional skills. And it's really important for parents to explore those as much as they are working towards towards supporting the difficulties. And then again, these are all basic, parenting skills that would be important for any child, more so if they have a behavior condition. And then in the management, I think it's really important to screen for comorbid conditions. As I've already said, if I treat the ADHD and don't treat the anxiety, we will again have the symptoms. And what will happen is, you'd start on low dose Ritalin, and then you take the history. They say the symptoms haven't improved. Then you up the dose, up the dose, up the dose. So you will keep upping the dose of the medication, whereas what we actually need to do is treat the anxiety. So it's really important to screen for anxiety, tics, specific learning disorders, and autism. Again, we know that autism, ADHD often overlap. We know that 80% of children with ADHD will have another condition other than ADHD. And we've already talked about how to stop the medication. So in our patient that we talked about, Rahul, we will be looking at non-pharmacological. We will be looking at parent coaching, because we have a father who loses his temper. We have a mother who's very probably subdued. And all these modifications that we've been talking about at school, home, lifestyle, and nutritional deficiencies will be treated. I would try, I think Ritlin, most of you will agree that he will probably meet criteria for ADHD. He will be going on a stimulant, and then we'll monitor and provide ongoing support. And I brought this, I put this slide here because last time I noted that with Dr. Anaga, somebody asked the question that can children with ADHD attend normal schools, or do they need to go to special schools? So I don't think children with ADHD need to attend special schools. If the ADHD is well managed along with the comorbidities, these children have a very good outcome. They can not only attend school, they can actually thrive and succeed. And as you can see, there are lots of famous personalities who have, who have had ADHD and have been pioneers and extremely successful people, from Bill Gates to Abraham Lincoln to Michael Jordan. And very recently, I saw Alia Bhatt's interview also. She has come up openly talking about her inattention. And that's about it. Thank you.
You can stop the screen share, ma'am. Any questions from the audience before we wind up the session? We had taken many questions during the session itself, and it was a very nice and interactive session. I would request our national coordinator, Samir sir, to give his comments.
It's a really an excellent presentation, na? And it's a really a good practical approach. What we really want for the ADHD as a being a practicing pediatrician, because we are come across such a patient, but we having a not a, that confidence when we are handling such cases. So with the continuous such type of the learning, we give the confidence of the utilization of the medication. That's the thing that your experience will help us to boost up our experience also. So it's really a great, and it's a pleasure to meet you in the this webinar platform, that at least we can able to get such type of the expert from the international level also. So thanks a lot for the sparing this time.
Thank you so much for asking me to talk on this topic. Like I said, 80% of my practice is ADHD. And I'm again very proudly a Indian trained pediatrician. And like I said, I've done my MBBS from Pune. So very, very happy, very close to my heart. Thank you.
All right. Thank you.
One question is there, which nutritional supplements can help?
So I think we have to know which deficiency we are dealing with. Usually it is iron or B12. And I think the standard recommendations for supplementation is iron, elemental iron in the dose of 4 to 6 milligram per kilo for 3 months. And then I repeat the ferritin. If the ferritin is normal, for another 1 month, and then you can stop.
One question is asked for regarding the presentation, but I just gave you that this will be the available on this total recording will be available on our website once this presentation complete. So anybody can reconsult it as and when required. Same this our topic, because it will be available on the YouTube of the Aacci also.
Today, unfortunately, Dr. Bhave ma'am could not join the session because of her health, but and so we missed her insights on the topic.
Yes.
But, the session itself was very nice. The flow, the content, as well as the interaction which happened, and ma'am shared her own experiences. So this perspective is many times lacking when we discuss cases with our Indian counterparts, because evidence and the protocols and the complete settings are not found. So it helps when somebody gives a different perspective from our own. Thank you very much, Dr. Upasana Kapoor, ma'am. It was
My
a very
pleasure.
nice session indeed. And we hope to
Thank
see
you.
you again on the Aacci platform.
Sure, anytime. Thank you.
I would like to thank all the audience who spared their valuable time. Even if you are have missed this session, you can watch on our YouTube channel this, and there are many other sessions related to other behavioral issues, adolescent issues, which are accessible on our YouTube page. So you can check there. You can visit our website aacci.in, and there you can see the various activities of Aacci, as well as you can see with the different educational content which is available. I Before the close, I again like to thank Samir sir, Bhavya ma'am for giving me this opportunity, and Dr. Upasana Kapoor for this very nice session. Thank you very much.